Welcome to the Practicing Clinicians Exchange podcast, Nursing Considerations for CDK4/6 Inhibitors in HR-positive, HER2-negative breast cancer. Today's episode features Julia LaBarbera, a nurse practitioner at UCLA Health in Santa Monica, California. Ms. LaBarbera will summarize key evidence on CDK4/6 inhibition in HR-positive, HER2-negative breast cancer and offer practical guidance for using CDK4/6 inhibitors in the clinic. This information was part of a series of presentations during a recent PCE Oncology conference. After listening, please visit PCE.is/ONC22 to access the slide sets from the conference and additional related activities, including a series of interactive breast cancer patient case simulations focusing on the application of CDK4/6 inhibitor therapy in clinical practice.
Hi. My name is Julia LaBarbera, and I'm a nurse practitioner working in breast cancer at UCLA Medical Center in Santa Monica, California. Today, I will be discussing considerations for advanced practice providers around the use of CDK4/6 inhibitors for patients with HR-positive, HER2-negative breast cancer. I'll start by first talking about new indications for CDK4/6 inhibitors and other targeted therapies in early-stage, high-risk, hormone receptor-positive, HER2-negative breast cancer. As we know, endocrine therapy is the mainstay and arguably the most important component of treatment for HR-positive, HER2-negative early breast cancer. Current guidelines support 5 to 10 years of therapy with either tamoxifen or an AI, or both, depending on the stage of diagnosis, lymph node involvement, menopausal status, and patient comorbidities. The addition of ovarian suppression with GnRH agonists like leuprolide or goserelin can be considered for higher risk premenopausal women and combined with either tamoxifen or an AI. Chemotherapy, either before or after primary surgery, can be considered for some women based on their tumor biology, such as the grade or size, and the patient's risk of recurrence. We can assess an individual's need for chemotherapy by using tumor genomic assays like the 21-gene recurrence score Oncotype or the 70-gene Mammoprint. In addition to endocrine therapy and chemotherapy, there have been several new and ongoing studies looking at the use of targeted therapies for HR-positive, HER2-negative early breast cancer, such as PARP inhibitors, PI3 kinase, AKT or mTOR inhibitors, oral SERDs, and of course, CDK4/6 inhibitors. I want to spend a quick minute highlighting the March 2022 approval of the PARP inhibitor olaparib in the adjuvant setting, which was based on data from the phase 3 Olympia study. This is a really important development and will change clinical practice. To review, PARP and BRCA are involved in DNA damage repair and are important mechanisms by which breast cancer can grow and divide. Blocking PARP helps to stop cancer growth and development and improves patient outcomes in both metastatic and early breast settings. In this study, individuals with HER2-negative early breast cancer and either HR-positive or HR-negative disease, plus a germline BRCA1 or 2 mutation, were randomized to receive adjuvant olaparib 300 milligrams twice a day versus placebo for 1 year. These patients had high-risk features such as lymph node involvement, tumor size greater than 2 centimeters, and lack of a pathologic complete response at surgery. Compared to the placebo, addition of adjuvant olaparib demonstrated a significant improvement in overall survival compared to placebo. So definitely consider germline genetic testing to identify BRCA mutations in those who appear to have a hereditary breast cancer or in those with higher risk disease who may benefit from this very important treatment. If your patient is BRCA negative, but still has high-risk features for recurrence based on tumor size, grade, and lymph node involvement, we should consider testing for Ki-67. Ki-67 is a nuclear antigen used to identify proliferating cells. It's measured as a percentage and gives you an indication of how many cancer cells are in a state of rapid growth and division. Higher numbers, 20% or greater, mean more cells are proliferating and can lead to poorer prognosis. Measuring Ki-67 in some individuals with HR-positive, HER2-negative early breast cancer is indicated to determine eligibility for adjuvant abemaciclib. Approval for adjuvant abemaciclib in HR-positive, HER2-negative early breast cancer was based on data from the phase 3 randomized controlled trial, monarchE. This study was designed to evaluate the rates of breast cancer recurrence in patients with very high risk and intermediate risk features of disease by adding abemaciclib to endocrine therapy. This study included men or women, again with HR-positive, HER2-negative disease, who were pre- or postmenopausal with no distant metastases. They had completed chemotherapy, surgery, and radiation therapy, and not more than 3 months on endocrine therapy. The patient population was divided into 2 groups. Cohort 1 included patients with 4 or more positive lymph nodes, or those with 1 to 3 positive nodes and grade 3 tumor and or tumor size of 5 centimeters or more. Cohort 2 included those with 1 to 3 positive nodes, a Ki-67 of 20% or greater, tumor grade less than 3, and tumor size less than 5 centimeters. Participants were randomized to receive abemaciclib 150 milligrams twice a day for 2 years in combination with endocrine therapy for 5 to 10 years, compared to endocrine therapy alone per standard of care. The primary endpoint was invasive disease-free survival. At 3 years, abemaciclib significantly reduced the risk of recurrence in the intent to treat population, with an absolute difference between groups of 5.4% and in the Ki-67 high group, those with a value of 20% or greater. This data led to the FDA approval of adjuvant abemaciclib plus endocrine therapy in October of 2021 for high-risk, node-positive, HR-positive, HER2-negative early breast cancer with a Ki-67 of 20% or greater. Recent data, however, show that the Ki-67 level is prognostic but not predictive of a response, meaning patients derived benefit with adjuvant abemaciclib regardless of their Ki-67 level. So it's really important to consider testing for Ki-67 in your lymph node positive patients to see if they will qualify for adjuvant CDK4/6 inhibition. Here's an example of how I've used this in my practice. I had a 36-year-old female diagnosed with hormone receptor positive, HER2-negative left breast cancer in September of 2021. She had lumpectomy and sentinel lymph node biopsy, which showed 1.6 centimeters of grade 2 IDC. It was ER positive 75%, PR positive 40%, and HER2 negative with an IHC of 1+. There were 3 of 6 positive lymph nodes. She received adjuvant taxotere-cytoxin, radiation therapy, and started ovarian suppression with an AI in May of 2022. We wanted to see if she would qualify for adjuvant abemaciclib, so we requested Ki-67 tested on her surgical specimen. This came out high at 30%. So with her 3 lymph nodes and high Ki-67, we were able to add adjuvant abemaciclib to her endocrine therapy. Next, I'd like to talk about the use of CDK4/6 inhibitors in HR-positive, HER2-negative metastatic breast cancer and briefly touch on strategies for identifying the best agent for second-line therapy. CDK4/6 inhibitors are the preferred first-line therapy in hormone receptor-positive, HER2-negative metastatic breast cancer in combination with endocrine therapy, either a nonsteroidal AI, such as anastrozole or letrozole, or fulvestrant. When choosing whether to use palbociclib, ribociclib, or abemaciclib, consider the patient's menopausal status, the drug's toxicity profile, drug-drug interactions, and any perceived barriers to patient adherence. All 3 of the CDK4/6 inhibitors have shown significant improvement in progression-free survival when added to endocrine therapy in postmenopausal women, with a median PFS of 25 to 28 months compared to 14 to 16 months with endocrine therapy alone. So nearly double the PFS of endocrine therapy alone. So far, ribociclib is the only agent to demonstrate overall survival advantage based on the MONALEESA-7 data, with a mean overall survival that's 10 months longer than endocrine therapy alone. We are still awaiting overall survival data with abemaciclib and palbociclib. Ribociclib is also the only agent to be evaluated in premenopausal women in the metastatic setting, so consider using this for your younger women with metastatic disease. While this data is truly compelling, we know that most metastatic breast cancers will ultimately develop resistance to endocrine therapy and CDK4/6 inhibition. The next line of therapy depends again on specific features of your patient's breast cancer, and we can use biomarker and germline testing here to help inform our treatment decision. A common method of resistance to CDK4/6 inhibitors is upregulation of the PI3 kinase AKT-mTOR pathway. Testing for and identifying a PI3 kinase mutation makes a patient eligible for alpelisib as second line in combination with fulvestrant. Next generation sequencing or companion diagnostic testing is available to identify a PIK3CA mutation. If no PIK3CA mutation is identified, patients can receive the mTOR everolimus in combination with the AI XMS stain. You can also use germline genetic testing here to look for a BRCA1 or 2 mutation, in which case you can use a PARP inhibitor such as olaparib or talazoparib as second line. Endocrine sensitivity or resistance also informs treatment options and sequencing of targeted agents or chemotherapy in metastatic hormone receptor positive HER2 negative disease. I'd like to address the management of adverse effects associated with CDK4/6 inhibitors so we can help identify the best drug for our patient and ensure our patients have the best possible response. CDK4/6 inhibitors are generally well tolerated. The most common adverse events are neutropenia and diarrhea. While these side effects can occur with all three CDKs, diarrhea is the most common with abemaciclib and neutropenia more common with palbociclib and ribociclib. Each carry a risk of interstitial lung disease, or ILD, or pneumonitis. So monitoring for new respiratory symptoms such as cough, shortness of breath, hypoxia, or fever at every visit is extremely important. I would like to highlight a patient of mine who developed ILD related to ribociclib. This was an 80-year-old female with metastatic hormone-positive HER2-negative breast cancer to the lungs, diagnosed in 2019, just a month after completing adjuvant AI. She started first-line therapy with ribociclib and fulvestrant in April of 2019. About 6 months later, she presents to the clinic with new onset of cough and dyspnea with exertion. We obtained a CT chest, which showed new development of peripheral reticulations and ground glass opacities in her lungs, possibly related to drug toxicity. We immediately stopped her ribociclib and referred her to pulmonology. She ultimately had a lung biopsy that confirmed fibrosis and interstitial lung disease. Her symptoms improved with discontinuation of ribociclib, and she continues on fulvestrant alone. Neutropenia associated with CDK4/6 inhibitors is not the result of cell death as you experience with chemotherapy. Inhibiting the CDK4/6 pathway causes senescence of the hematologic precursor cells, resulting in neutropenia. In other words, white blood cell production is put to sleep with CDK4/6 inhibition. Once therapy is held or stopped, the white blood cell count will recover. Because of this, ribociclib and palbociclib are taken daily for 3 weeks on, followed by 7 days off. Abemaciclib appears to have less neutropenia and can be taken continuously. In my practice, I monitor a CBC and DIF every 2 weeks for the first 2 cycles with ribo and palbo. After that, I check monthly prior to the start of a new cycle, and I don't start the next round until the absolute neutrophil count is 1,000 or greater per treatment guidelines. Dose reductions are indicated for grade 3 neutropenia at day 1, and if the ANC does not recover to at least a grade 2 within 1 week. Permanently discontinue if neutropenia persists despite 2 dose reductions. Advise patients to hold therapy with any infection and promptly report a fever. I recently started a 67-year-old female on palbociclib 125 milligrams daily with fulvestrant for hormone receptor positive HER2 negative metastatic breast cancer to the bone. Her CBC at baseline was totally normal. At cycle 1, day 15, her ANC was 650, grade 3, and she continued at palbociclib 125 to complete the cycle. By cycle 1, day 22, her ANC was 400, which is grade 4. We did not start the new cycle, and it took 2 weeks for her ANC to recover to 1,300. We reduced the palbociclib dose to 100 milligrams daily and continued at this dose for cycle 2. She continues on this currently with manageable neutropenia. While diarrhea can occur with any of the CDKs, it's most associated with abemaciclib. Across the 4 trials with abema, 81 to 90% of participants experienced diarrhea, most of this grade 2 or grade 3, and there were no grade 4 events. It's extremely important we discuss this with patients from the outset. The median time to onset of diarrhea is within the first 6 to 8 days. Counsel patients to promptly start antidiarrheals with any watery stools or more than 3 bowel movements above their baseline. Also encourage increased oral hydration, ideally 1 to 2 liters of fluid daily. Water or electrolyte drinks are fine. And try bland or low fiber foods until the diarrhea improves. In severe cases, you can prescribe atropine. Dose reductions and interruptions would be indicated for grade 3 diarrhea or grade 2 diarrhea that persists despite maximal use of antidiarrheals. Follow electrolytes, magnesium, and phosphorus every 2 weeks for the first 2 cycles with abema, then monthly thereafter until clinically stable. There are a few important side effects of CDK4/6 inhibitors that we need to consider when tailoring treatment for individual patient characteristics. Abemaciclib is associated with increased risk of VTE, so you will not want to use this for anyone with a history of clotting disorder. Advise your patients to monitor for and repeat any symptoms of thrombus or PE. Ribociclib is associated with QT interval prolongation, but this is infrequent and not a class effect. Follow an ECG at baseline and for the first 2 weeks for the first 2 cycles of ribo. Monitor electrolytes and look for potential drug interactions with other QTC prolonging agents. Both abemaciclib and ribociclib can cause hepatobiliary toxicity, so monitor liver function tests monthly until stable. Lastly, I'd like to talk about some ways we can promote patients to comply with oral therapy despite the challenges with dosing and side effects that I've mentioned. We know that adherence to oral CDK4/6 inhibitors and targeted therapy is necessary for drug efficacy and improved patient outcomes. As clinicians, we need to identify key barriers to compliance and promptly implement clinical management strategies as soon as possible. Common obstacles to adherence are complexity of the dosing schedule, ability or flexibility to attend multiple clinic visits, rapport with clinic staff or providers, ability to receive instruction in their primary language, cost of therapy, and lack of social support. It's important to recognize these factors to assess the best ways to intervene. Assess a patient's readiness to receive new information whenever the disease progresses or new treatment is required. We may need to set aside a separate visit or phone call to review dosing instructions and symptom management before the patient starts new treatment. We should monitor and assess for understanding at each follow-up visit and re-educate as needed. Set appropriate expectations with patients about what it looks like to be treated on a CDK4/6 inhibitor. Abemaciclib is twice daily dosing continuously, whereas palbociclib and ribociclib are 3 weeks on, 1 week off. These can be taken with or without food, except for palbociclib capsules, which need to be taken with food. Patients may want to use pill boxes to stick to the prescribed regimen or follow a calendar. It's important to stress that dose modifications, if needed, do not affect efficacy per data from early studies with palbociclib. Advise patients of potential drug interactions with strong CYP3A4 inhibitors and screen for this from the outset. Patients will also want to avoid grapefruit on CDK4/6 inhibitors. Review side effects and red flag symptoms to report with the provider. Make sure patients have a thermometer at home and know when to call the clinic with any new fever or illness. Ensure that patients have access to supportive care medicines like antidiarrheals, antiemetics, and understand when to incorporate these therapies. Enlist your pharmacist colleagues to reach out to patients for support and address drug-related questions and pharmacologic strategies for symptom management. Always consider the financial impact a treatment may have for a patient. Cost can be a major barrier to access and adherence with this class of drugs. Look into support programs like copay assistance from the drug manufacturer or grant initiatives for federally funded insurance carriers. Advise patients not to reduce or withhold treatment because of access issues, and enlist social workers or local cancer support programs to identify community resources that may be available to your patients. I hope you've enjoyed my talk today about CDK4/6 inhibitors, both in the early and metastatic settings. Thanks so much for your attention. If you would like to find some additional information, please visit the PCE website, practicingclinicians.com, and I encourage you to learn more with patient case simulations that are designed to provide practical experience in managing hormone receptor positive, HER2 negative, early and metastatic breast cancer, and use of targeted therapies like CDK4/6 and PARP inhibitors.
Thank you so much for listening today. We hope that you enjoyed this podcast and invite you to participate in other activities relating to the PCE Oncology conferences by visiting PCE.is/ONC22.